like to move forward to our next session, HPV. I would like to call on stage the chairpersons, Dr. Manas Roy, Dr. G.R. Verma, Dr. Tamanas Chaudhury, and Dr. Asit Arora. Thank you.
Hello, good morning, everyone. I think we are going to start this session. This session basically consists of something little uncommon kind of surgical interventions, which not many of us are probably doing routinely. This first one is the difficult uncinate cancer approach. May I request Dr. Shailesh to come and present this.
Very good morning to all of you, and thank you so much to IASG for this invitation to speak on the difficult uncinate process cancer. So when we speak of uncinate process cancer, let's not forget the work of Dr. Nakao, and this particular picture will emphasize to you that it's not just the uncinate process, but the tissue beyond and medial to the uncinate process, which very clearly tells you the plexus of nerves and lymphatics, which are extremely important when you do a complete resection for a localized cancer. So this is one of our pictures which shows you that after a good Cocker maneuver, not a bulky tumor, but I'm trying to take you to the basics before I show you some clips of the difficult ones. But this is supposedly where the uncinate process ends. But next to that is the tissue which also needs to come out. The vein is far away. What we are doing is working to the right of the artery and behind the artery. The minute we speak about the artery, I think most of you know what we are talking about, and that's the superior mesenteric artery first approach. And in this situation, we have learned this about 10-12 years ago, individually speaking, where we have compared the infracolic approach with the right medial approach, can be done safely. And unless you do this routinely, you will not be able to do it in difficult, larger tumors. The second picture is the one which shows you that you can access the artery through multiple different avenues, and in those bulky tumors, in those uncinate processes which go way beyond, you will need a combination of these approaches to safeguard the artery, get the artery away, be safe, and yet do a complete radical clearance. The third picture tells you about the LV1, LV2 and LV3, and in bulky tumors you will have a situation where a large number of cases will be LV3, that's peri-adventitial dissection, even subadventitial dissection if patients have responded very well based on the work of Yi Miao from Nanjing. So that's the vein, that's the uncinate, but you need to create a tunnel along the SMA. This is a view from the right medial approach, and this is what should be the guiding principle, however big or large the tumor may be. I'll show you a video clip to tell you how we look at it. So you have a lady of 56, mass in the pancreas abutting vein and artery, non-metastatic SMA abutment 180 degrees, combination of chemo, SBRT, stable for a year, dilated pancreatic duct, SMA giving off an artery which is replaced going to the right liver, and there you see the conventional fat planes are missing. You have the tumor abutting less than 180 degrees of the artery, and again you will see over here that this is where things stand in a case. Despite giving the patients a lot of treatment, you might have some degree of reduction, but now this kind of an uncinate process or a tumor, it's way beyond and way behind. So the plan is still to do a resection. And you can see this is a camera from the left side, post-chemotherapy, radiotherapy. We are talking of LV3 here. The looping of the superior mesenteric artery is done. Of course, it's a combination of SMA first and sometimes an hour or 2 hours before you can do this. For constraints of time, we just show you the highlights that we divide the neck early in these cases, and what you see is that's the vein, that's the tissue which has been treated. If you have concerns, do the frozen as well. The artery is under control in the red tape, and what we are doing is LV3 and a combination of subadventitial dissection where you go behind the tissues in a way that you safeguard the artery. In these cases, you take your inferior pancreatico-duodenal, etc. much later. Remember the paper of Chris Wolfgang. Here you see the IPDA being taken at a much later stage, and then the clearance of the triangle also is important if you want to offer an R0 resection. So this is how we would do a Whipple resection with an artery or a vascular resection for an uncinate process tumor. And at the end of it, is this all worth it? Because of better chemo, radio and surgical concepts, I think you have more role for aggressive surgery because in the last 10 years, you've got better response to modified FOLFIRINOX and other forms of treatment. So this patient has earned this surgery at the end of 1 year of non-surgical treatment avenues. We have some evidence, obviously low level evidence, which tells us that the SMA first has got its advantages, but this is multiple retrospective single center cohort studies. There is one randomized trial which has shown no benefit, but I have genuine concerns, so as the rest of the world, about this trial because they compare a standard pancreatoduodenectomy with an SMA first. To me, there is nothing standard. It's like comparing TME versus less than TME. So I don't know how it works, but this is how it is. We have data which shows that when you do an SMA first or otherwise, your pathology at the end of it is going to be depressing. You are going to get 57% of head tumors which are R1 even without a vascular resection. Difficult uncinate or simple uncinate, these are the figures which you can't ignore by the Leeds protocol or the Royal College of Pathologists. The other part is that when we approach this, it's not just surgical skills and technique. There are two important messages from this Prodige trial. You can see the two Kaplan-Meier's and how they separate, and clearly big advantage of modified FOLFIRINOX over gemcitabine. But adjuvant FOLFIRINOX demonstrates an effect in the adjuvant setting even after upfront resection. It means that there is microscopic disease. Never forget, pancreatic cancer is a systemic disease. The second picture shows the early drop-off in the red circle. So you can do great surgery, but you will have number of people who fail. This is driving the reason why we want to do neoadjuvant treatment, and this is then what we commonly see: SMA first, LV3, tumor hanging on the vein, and then the triangle tissue is also completely cleared, and then we get an R0 resection. I'll show you another clip. I'm fully conscious of the time available, but within 12 minutes, it's not easy, but we will do our best to show you. So now, if you want to do this, this is a standard Whipple resection, but even in a standard Whipple resection, that is what we would do, that the vein is far away, and what we are going to do is, after exposing the vein, the first jejunal and the colic veins draining into the SMV, the focus is behind the SMV and swinging the artery to the right is what the plan would be when we continue going ahead. So this becomes a standard where the focus of trying to expose the SMA is the primary approach for any case, even a periampullary tumor. Just to highlight to the younger members of this audience that get used to being on the artery all the time, because then the so-called difficult uncinate cancer is just another tumor which requires some planning, and then you will be able to get it out completely. This is very much standard. I don't need to show you that when you divide and swing, if you go behind the vein and behind the artery by a combination of SMA first, it's very easy for you to do a Whipple resection and proceed. This I don't need to show you because this is standard Whipple resection, no big difficult uncinate. The same can be done in robotic surgery in well-selected cases. Learn to be on the artery. We have a selection bias. We have not yet done 100 robotic resections, but we are close to it. And once you do this, I think even the more difficult tumors sometimes we will be able to resect and get it completely out. And then of course there is this divestment, which I can show you another case, right medial approach, artery exposed, bulky tumor, post chemotherapy, post radiotherapy, and then we would be working on these. So in these cases it's possible, again you create that groove. Remember the picture that I showed you of the vein, artery and the uncinate and the mesopancreas, and then you are in a position to be able to work on the artery and go even up to the celiac axis. Here there is a vein clearance as well, and then you are able to do that. The Tata experience as regards borderline resectable disease, we can see that we are doing more and more of neoadjuvant. This is a series of 201 patients as they come. It's not a prospective study, but we clearly know that there is significant pathological downstaging, improved R0 survival, and those who get a resection, perhaps the survival is also better. So one is to know how to do it technically, the other is to choose the patients, the third is to have the timing of surgery changed and tailored to an individual patient. This is my closing slides, Tata data. Even in the COVID year, we've done 190 Whipple resections. This year, we are again on schedule. And this is possible simply because we know that we have the ability and the experience to have the SMA first as a standard, LV3 as a standard, vascular is standard, subadventitial, we are trying to standardize it in selected cases. So we do believe that these approaches make it easy to do a vascular or a vein resection. In large uncinate and neck and body tumors, this is what the BJS paper of 2017, which I published with Sanjay Govil and John Windsor, it shows that you will be able to take it out. And also when only vein or artery involvement is suspected but not there, even in those cases, you will be able to do that. Triangle clearance, we don't have enough of data, but knowing that 8A is conventional but 8P is not part of standard lymphadenectomy. In bulky tumors, post-chemo, post-radio, we are running a prospective study currently. One of our younger good fellows here who is here, Dr. Verti, is working on this particular study. I happen to be the president of the APHPBA meeting next year in Bangalore, and I'm also the president-elect of the Asia Pacific Association. So I take this opportunity of this platform to invite all of you for what should be an outstanding meeting by any standards. That's my promise and commitment to all of you. Myself and Dr. Nagesh would be doing this. Closer, next month at the Tata Hospital, we have our annual OncoSurge event, a huge success for more than a decade and a half. Next month, we will also show a robotic Whipple and other aspects of surgical oncology. The work that I present is on behalf of the entire team that I have been privileged to lead. Thank you so much for your kind attention.
Excellent presentation. I think before I'll just open this the paper for the question and comment, I have just two questions actually. What is the criteria of you to say that this is a difficult caudate lobe? That's number one. Number two, you made a comment that even in conventional or the traditional pancreatic adenectomy, one should follow the SM approach first. Did you find the positive margins in those patients as standard cases just to justify that should be a standard, or it is just to gain experience so that you can land yourself you are better prepared in difficult cases?
So I'll answer your second part first and then tell you about the case selection for the uncinate process. You first do it because you need to be comfortable, not necessarily because it will. I did not have the conviction in 2009 that I need to do this because I'm going to cure pancreatic cancer. We all know this. But unless you do it in a simple case, when you get a difficult case, you can't wake up in the morning and say, now I will do SMA first. So I think a statement which I have heard from my father, I always tell it to my younger people, unless you sweat in peacetime, you will bleed in wartime. So you need to do it simple cases well, make it a routine. But now in 10 years time, because we have got improved results from chemotherapy and radiotherapy documented, Just the way you have FLOT in gastric cancer making a big difference in gastric cancer, you have the same with modified FOLFIRINOX. So now the R0 resection rates have improved as compared to what R0 were 10 years ago. So that's why I made one comment in my talk, that now when you do the bulkier tumors, because the practice is done, the SMA approaches are established, the LV1, LV2, LV3 approaches are established. Beyond LV3, subadventitial dissection, avoiding an arterial resection but short of arterial resection is done. And those tissues in today's specimens in about 60 to 70% of the times are negative now post chemo radio. So about 70 to 80% neoadjuvant meta-analysis and studies have shown that there is R0 status at the margin post neoadjuvant. So now I'm convinced after 10 years of keeping on doing this that it helps to improve your R0. And today I think local failure would mean bad surgery. We still know that we are dealing with an aggressive cancer which fails elsewhere like a pancreas cancer. So that's the second part of my answer. Your first question was about case selection. I think we all have our selection biases as we begin our journey of pancreatic surgery. So a smaller tumor far away from the blood vessels on a triphasic CT scan, you know that you have enough of uncinate which you can study. A pancreas protocol CT scan is first thing that we would do. A relationship to every vessel, namely the SMV, SMA, celiac axis, common hepatic, in terms of length of contact, whether it's abutting, whether there is any deformity, and circumferential contact in terms of degree. So this is standardized by our surgeons as well as our radiologist as a part of synoptic reporting at Tata for the entire team. So the minute we know that we are close to it or in danger, these patients go for neoadjuvant, and then we already know beforehand that this is going to be a difficult SMA first, this is going to be triangle, all this is planned beforehand.
So primarily in the locally advanced tumor following chemoradiotherapy, if you say it's nearly 180
Yeah.
or little approaching 180,
SMA.
they become the candidate.
But the
Right.
simple periamps,
Right.
remember that cholangiocarcinoma, 20% of those, our own documented data, and 7% ampullary tumors are also R1 positive.
Right.
So there is a justification actually. In our country, we see far more periamps than PDACs. We have even more justification for doing a good SMA first.
Yeah.
We might improve things.
Right. Now, any questions from the house, please?
Excellent presentation, sir.
Thank you.
Sir, how far you are comfortable with the pre-op CT before taking up all these cases, and how many times do you find some interesting findings while doing the surgery, and you retrospectively think that this was not mentioned in the CT or something like that?
So I think less and less, to give you a simple answer. High quality triphasic CT scan evaluated on the console with your expert radiologist, but before you go to the radiologist, see it yourself. Don't see or read any reports. That's a standard again in our surgical team. See the CT yourself, give an opinion, then study the report, and then go to the radiologist. So I would say 95 times or 97 times out of 100, there are no unexpected shocks or surprises on the operation table. There are sometimes shocks and surprises, and then we go back and see, we realize that we have failed or not given enough time to study the scans. So yes, the mind has to keep on working on the operation table unconnected with the CT scan. What you see, what you think, and what you do is the best. But I think CTs make life very easy now, very, very easy. And everything, which is what I showed you in the movie. You may not get a size reduction, but you will be able to show what is stable disease, how is the halo around the critical blood vessels, how much is the length, how much is the vein available. All that is available, not an issue.
Good morning, sir.
Morning.
That's a nice presentation.
Thank you.
Sir, two questions. First is the ABC of pancreatic surgery that we often heard of you. And second thing, your take on radiotherapy. It's locally advanced.
So ABC is well defined by the IAP publication of IASGCON 2018 pancreatology, and you know that A is anatomy, which is what we have discussed. B is biomarker. The only good biomarker, unfortunately, in pancreas cancer in the absence of obstructive jaundice is CA19-9. You should give it some importance. And the third thing is patient's condition. We are not technicians, we are not treating reports, we are treating human beings. So factor in A, B and C, get a green signal for all A, B and C, and then go ahead with more aggressive, complex forms of treatment. That's the first question. Your second question was on
role of radiotherapy.
Radiotherapy. The Alliance trial by Matt Katz from MD Anderson today hasn't shown the effect or advantage of hypofractionated radiotherapy in addition to modified FOLFIRINOX. So do we have level 1 evidence to justify that you should do radiotherapy? No. In an individual selected case, and we would do that more with tumors which are abutting or in contact with the artery, when we are planning a divestment procedure, when we are planning Applebee's and celiac axis resections, when they have completed their chemotherapy, the biomarker is okay, patient has withstood chemo, performance status is okay, but the radiology still shows that everything is, there is no reduction in size as such after so much of treatment. Sometimes we are adding in an individual patient SBRT, like I showed you in the first video, where you could clearly see the impact of radiotherapy as well. So case to case basis, not as a routine as yet. The world doesn't have evidence for it as yet.
So do you find any difference if we give radiotherapy to our patients and then we are doing a divestment procedure and sending those for the frozen? So
Frozens are negative, because if they are all going to be positive, what are we doing? Arterial resections is not the standard of care in pancreas cancer. Be selective. It's your selection bias which will give you some good advantages of arterial or divestment procedures. It's not for all comers. It's about 20%. So out of every 10 patients who are treated with what I spoke to you, 2 or 3 are going to get an arterial resection or a divestment procedure.
Thank you.
If I may take a minute, I think from the house, see, you need to have a PACS in the all hospital. There's a CT plate that's very difficult. And I think we all should move towards MDT to decide which patient we need. Shailesh, thank you very much. Thanks.
One small.
Thank you so much.
We started early, so we can have one last question.
Sir, does it happen that you are given a chemo radio, got a CT scan which shows a free vessel now, artery? While dissecting, you find an extensive desmoplastic reaction over there.
Yeah.
Then how do you decide whether it is free or
Still
not?
go on the artery and take everything out. Sometimes you have to take veins as well out, otherwise you will never go there. To believe that all of that is desmoplasia is backing off from critical structures and running a risk of an R2. So to me that should not happen. In fact, it should exactly be the opposite. If you are wanting to be aggressive in your well selected patient, you may do some vein resections where the final pathology report says no tumor infiltrating the vein. This is well documented worldwide. As regards the artery, you can get onto the artery, the picture I showed you, the video I showed you, where you take off the tissue from the artery, send it for frozen section. But still you will completely skeletonize the artery bare, because otherwise you are not achieving and you are running the risk of leaving behind a disease which is notoriously resistant despite good FOLFIRINOX and radiotherapy. Because then, if that doubt is a large one, best is to back off and not do, which is fine, which is a mature approach in selected cases, absolutely fine.
That is what we have. Actually, we have to back out in some of the cases in spite of having a good radiological picture of it being resectable.
Yeah.
I think we should stop now.
Okay.
Thank you very much.
Thank you.
Thanks.